The next speaker is Dr. Vivek Nimje, and also requesting Dr. Divya to be ready for the talk after that. So Vivek is going to present his paper on role of anterior segment OCT in evaluation of fungal keratitis. Are you ready, Vivek?
Yes.
Yeah, please start the timer.
Good afternoon, everyone. I will be discussing on role of anterior segment optical coherence tomography in evaluation of fungal keratitis. Fungal keratitis is widely distributed fungal infection of the cornea caused by broad spectrum of filamentous fungi and yeast. It accounts for generally 30 to 40% of corneal ulcer in India. The clinical features such as dry looking corneal ulcer with feathery margin, intact epithelium with deep stromal involvement, satellite lesions, endothelial plaques. It is a sight-threatening condition. Normally, slit lamp biomicroscopy is the routine tool clinically used for the examination of fungal keratitis. It is difficult to measure the depth of corneal infiltration and associated corneal edema by slit lamp biomicroscopy. As a result, in vivo information about the corneal changes and tissue response to treatment is limited. ASOCT, it is non-invasive, non-contact imaging device. It provides the detailed structure of anterior part of the eyes. It quantitatively assesses the depth of stromal infiltration. It also measures the width of infiltrate and the corneal thickness. OCT can quantify the corneal changes which help grade the severity of the disease and assess its progression. Aim of the study is to assess the anterior segment OCT in evaluation of and monitoring the progression in fungal keratitis. It is hospital-based observational study of 6-month duration conducted in Department of Ophthalmology, Assam Medical College The 20 patients diagnosed with fungal keratitis were included in the study. A method of data collection, a thorough clinical history including age, sex, occupation, symptoms, progression was taken along with the general and local ophthalmological examination using slit lamp examination. Clinical diagnosis confirmed by corneal scraping in all the patients, and the samples was sent for gram staining, KOH mount preparation, culture and sensitivity. ASOCT imaging and clinical slit lamp examination were carried out simultaneously on day of presentation, subsequently on day 7, 14 and 21 of treatment initiation. A standardized scanning protocol was used for all the patients. Corneal thickness and infiltrate thickness were measured along with the axis perpendicular to the horizontal axis of the scan at the center of infiltrate in all the cases. During treatment, corneal perforation occurred in one patient. There was a male preponderance in our study. Corneal thickness at baseline was 644.8 micron at presentation, which then subsequently reduced to 596.8 at day 21. Infiltrate thickness was at the day of presentation was 396.2 micron, which then reduced to 323.3 on day 21. Infiltrate width could not be measured in all the patients because of limited scan size in standard spectral domain ASOCT. Thus, limbus to limbus image could not be taken with the help of ASOCT. The mean infiltrate width on day of presentation was 5.6, which decreases to 4.5 on day 21. Different ASOCT patterns were found in our study, such as epithelial plaques, epithelial defects, stromal edema, stromal infiltrate, stromal thinning, stromal cystic lesion and endothelial plaques. These are some of the image showing the hyperreflective area with posterior shadowing. This image shows the endothelial plaques. There is a epithelial defect seen which shows maybe because of the drug deposition or pigmented area. This image shows the sloping edge along with the stromal thinning. This image showing the stromal cystic lesion, which is also suggestive of the necrotic area. Slit lamp biomicroscopy, it is a gold standard method for diagnosing and monitoring of corneal infection, but it has some disadvantages. It is a subjective method and assessment of depth of infiltration is difficult in the presence of corneal edema. ASOCT is extremely useful for identification, measurement and monitoring of the size, age, margin of the ulcer. Also the depth and extent of infiltrate and measurement of corneal thickness even in the presence of corneal edema can also be taken with ASOCT. Different ASOCT patterns such as epithelial plaque, stromal edema, corneal thinning, epithelial scar without epithelial defect, endothelial plaque, stromal cystic lesion could be identified easily, which is often difficult to be appreciated by slit lamp examination. Namrata et al. Studied the ASOCT in fungal keratitis. They measured the corneal thickness, corneal infiltrate thickness, infiltrate width on serial ASOCT scan. Corneal thickness, infiltrate width could be found maximum on day of presentation and decrease significantly with treatment on follow-up.
So your time is up, doctor. So you can stop here. This can stop here. No, because the time is up.
Yes.
That's how this goes.
Yes.
So if there's any quick question, we'll take that up.
How is this monitoring by ASOCT going to change the way you manage your patients?
Yes, ma'am. We measure the three parameters: corneal thickness, infiltrate thickness, also the infiltrate width. By also the in ASOCT, we can measure the signs of scars such as hyperreflective area with defined margins. That's how.
Okay, thank you.
Thank you very much, Vivek. Very nice. You must try to stick to time. So I'm sorry I had to be the bad guy over here. Very good.